Okay, we are going to do a quick video on medications from chapter 43. So if you want to turn to page 616 in your textbook, you can follow along with this brief and fast overview. This is material that was covered in week 10. Unfortunately, we had a holiday, so you'll recall that most of the medications in this chapter we've already discussed. These are diuretics. These medications were discussed when we talked about hypertension, but we'll go into a little bit further detail now. The chapter is highlighted with some bullet points for you to pay attention to. So if you have the online resources, please open up and have a look at those. If you don't, you may want to follow along with your textbook and highlight some specific sections. Keep in mind, this is pharmacology. We want you to have an understanding of the anatomy and physiology, but that's not really how we're going to be testing the concepts. We believe that it's important for you to understand the functional unit of the nephron, etc., and the ascending and the proximal and distal tubules. This is the functional unit of the kidney. There are about over 1 million in each kidney, and its job is to regulate blood volume and excrete waste products and hold on to or release important electrolytes. So there's the exchange happening here in the production of urine. So this is the blood. The kidney arteries are coming in here, wrapping in Bowman's capsule. This is the glomerulus. And then urine is being made, and important electrolytes and fluids are being reabsorbed. And this is the S is for secreted. So the kidneys play an amazing role in helping us maintain homeostasis with electrolytes, with fluid balance, with acid-base imbalance. And so they do a number of important things. They also secrete a hormone called epoetin, which helps produce red blood cell production. Sorry, I had to answer my phone there for a moment. Again, review renal failure. You'll recall this concept in your anatomy and physiology concept course. I think it's important for you to understand the different levels of renal failure, but you'll get more of this in second year. So there's acute and chronic renal failure, and there's a new word here called azotemia that we'd like you to be familiar with. So renal failure can be classified as acute, meaning that it's happened abruptly, and or chronic, meaning it's frequent and recurring, lasting longer than 3 months. And so acute renal failure requires immediate treatment because retention of nitrogenous waste products can be very hazardous to the body. This is known as azotemia, when we have nitrogen and urea building up in the blood, and it will result in death. So it's important for us as nurses to recognize signs and symptoms of renal failure. And some of the earlier complaints will be very generic things, and you can read about them, but they might be complaints of fatigue, exhaustion, changes in level of energy. We can do basic diagnostics tests known as urinalysis, and this allows us to look at the components of urine, so the electrolytes or any waste products. We can also draw blood work in a lab and determine if there's any buildup of blood urea and nitrogen. Moving forward, the nurse's role is recognizing and responding to acute renal failure or chronic renal failure. Once it's diagnosed, all nephrotoxic medications should be either discontinued or used with extreme caution. If they are required, then we would want to double check with a physician to make sure that they are necessary and whether or not there are any non-nephrotoxic alternatives that we could consider. Common nephrotoxic medications include NSAIDs, which we'll be talking about this week, aminoglycoside antibiotics, and whatnot. So when in doubt, double check these. All ACE inhibitors, so keep in mind your medications that end with pril could be considered nephrotoxic. So if you have renal failure or damage to the kidneys or elevation in your creatinine or your bun, these are medications you'd want to consider double checking with the prescriber, whether it be a nurse practitioner or doctor, and seeing whether or not we should continue giving them. The mechanism of action when it comes to diuretics is to increase urine output by decreasing sodium reabsorption. So by expelling sodium and chloride, we remove fluid from the body, because wherever sodium likes to go, fluid also likes to go. So we'll use it with edema, hypertension or high blood pressure, renal failure, and again, used cautiously, diuretics with renal failure. But that's a component or a concept that we'll get more in depth in second year. But most diuretics block sodium reabsorption, therefore fluid follows it. One thing that it would be important to teach our clients is to take diuretic medications in the morning. Loop diuretics are probably the most effective diuretics. They're considered the high ceiling diuretics. I consider these the big guns of diuretics. They're very, very powerful and potent, and they work very fast in a very short time frame. Loop diuretics can be used to reduce edema associated with heart failure or liver cirrhosis, also with chronic renal failure. So it seems funny that we would give medications to increase urinary output when the kidneys aren't working. But we would do that with extreme caution. Lasix is probably the most commonly prescribed loop diuretic, and the prototype is available on the next page, or 314, for you to look at. The big danger with a loop diuretic and a thiazide diuretic is hypokalemia, or low levels of potassium. Because potassium is going to be excreted, we're really concerned with making sure that you know how to assess what hypokalemia looks like and sounds like in patient complaints or in your nursing assessment. So look at hypokalemia in your fundamental nursing textbook and maybe jot down some ideas of what clients might complain of that might be subtle signs of hypokalemia. Potassium loss is a particular concern for clients who are also taking digoxin. So digoxin and a loop diuretic together really put your client at risk for hypokalemia. Be on the lookout for that. That's a potentially life-threatening I'm struggling on my words. Potentially life-threatening when your potassium levels drop too low. You'll remember potassium levels are typically 3.5 to 5.1 or 5.0, depending on what diagnostic book you're looking at. So you would not administer this medication if your potassium levels were already low, or if your patient was complaining of signs and symptoms of hypokalemia. Careful monitoring of their blood pressure, because we know that this medication is going to reduce blood volume, and also electrolytes like potassium. Those are important labs and vital signs to pay attention to, and hold the medication should you see any hypotension or hypokalemia. Also, watch out for other medications like lithium, ototoxic, that's ears, toxic medication to the ears, NSAIDs, nonsteroidal anti-inflammatory medications, and other antihypertensives. Please pay attention to pulse and for blood pressure. So if blood pressure is dropping and pulse is going up, that's usually a sign that your client might be dehydrated. Again, if your blood pressure is falling and your heart rate is attempting to compensate by speeding up, that's usually a sign that your client may be dehydrated. Other signs and symptoms could be weight loss, complaints of fatigue, dry, cracked mouth. So be on the lookout for these types of things. And periodically, clients need to know that they need to check their labs, especially potassium level. And they need to know that, because if they get put on this diuretic, they may not think to follow up with their doctor, and then they could get into a problem of hypokalemia. So you have to teach them that this does eliminate the potassium from their diet or from their body. So they would want to encourage potassium intake in their diet to compensate for that. Also, we want to have them weigh themselves daily, maybe write on a calendar daily or weekly what their weight is, so they can keep an eye on that. Monitor blood pressure and caution them that they might experience some orthostatic hypotension and whatnot. If they do experience any hearing changes whatsoever, this medication can be ototoxic or hard on the ears. You can cause permanent hearing loss if it's given and we're not paying attention to the levels in the body, and we're causing Lasix overdose. So typically this happens with IV administration, not with PO, but in any case, if your client experiences any changes in their hearing, this is something we really want to report right away. Also, if there's any signs and symptoms of gout, they would want to report that immediately as well. All diuretics, including thiazide diuretics. We moved on to the next column of diuretics. So we now have a different classification called thiazide diuretics. These are considered to be the safer alternatives to diuresis or eliminating fluid from the body. They have fewer side effects, so they're the most commonly prescribed. That being said, they're not safe. They're as dangerous. They do have side effects, so important for clients to be educated. Thiazide diuretics also drop blood pressure and also drop potassium. So in your first column that says, does it affect any labs or vital signs? I'm hoping that you have it drops blood pressure and potassium. It also may elevate glucose. So keep in mind that if they are diabetic, they may want to monitor their sugars more frequently. Also, if they're hypotensive or hypokalemic, you would want to hold the medication and consult with the prescriber. And again, the health teaching would be very similar. Take it in the morning. Increase increase potassium in your diet. Weigh yourself daily. These are very, very similar health teaching. What else? Oh, protect skin from exposure to sunlight. This is unique to this one. Thiazide diuretics may cause some photo sensitivity, and so keep that in mind. All right, moving forward. Here's an example of a thiazide diuretic, hydrochlorothiazide or chlorothiazide diuryl. Give oral doses in the morning to avoid any interrupted sleep due to nocturia. That's urinating during the evening. And one episode in the evening is not a big deal. Maybe 2 episodes in the evening are not a big deal, but anything more than 2, we consider that to be nocturia. We don't want to interrupt their sleep. Sleep's so important. Have a read, and then if there's anything missing, keep in mind you won't be giving IV administration of this medication, so you don't need to know that. Potassium-sparing diuretics is the another classification or version of diuretics. So I'll just zoom in here. Aldactone is the medication that you'll get familiar with, or spironolactone. Aldactone does not cause hypokalemia. It actually may cause hyperkalemia. So it's rare, but it can happen, especially if people are taking high levels of potassium in their diet. So hypokalemia is one of the most severe side effects of thiazide and loop diuretics. So if that is a significant problem for your clients, physicians may switch them over to a potassium-sparing diuretics. And so keep in mind, you do not want them adding any potassium-rich foods to their diet. It is the exact opposite. Intake of excessive potassium can lead to hyperkalemia, and that would be as dangerous as hypokalemia. I think it's important that you know the signs and symptoms of hyperkalemia, and here they are: irritability, anxiety, abdominal cramping, irregularities in their pulse or heart rate. That could be tachycardic or fast and butterfly feeling in their chest, palpitations, etc. So watch out for their liver and kidneys. Pay attention to those. Think about what lab levels tell us about kidneys and liver. Signs of hyperkalemia: if they experience any of these, they need to report them immediately. Tell them to avoid using any salt substitutes like Mrs. Dash. Salt substitutes are actually high in potassium. They're low in sodium, and so they're high in potassium for that taste. So you wouldn't want to. This is definitely something to star. You do not want your clients taking any kind of salt substitute and a potassium-sparing diuretic. The two do not go together. Very dangerous and could cause significant harm. So let's imagine for a second your client was started out on a loop diuretic or a thiazide diuretic, and they've been on that medication for a number of years, and they've been following a diet that is low in salt, and maybe they've added a salt substitute to their diet to help keep their blood pressure down. Suddenly, they have experienced significant episodes of hypokalemia, so the doctor changes their medication over to a potassium-sparing diuretic. But here's where we as nurses have a vital role, is to assess how they were managing their blood pressure before, and if it was using salt substitute, that we counsel them that this medication and salt substitutes do not go together. Do not discontinue this medication abruptly unless recommended by a healthcare provider. Take the medication immediately as ordered and as early as possible. Keep a log of your symptoms. Weigh yourself daily. Again, keep in mind you may have orthostatic hypotension changes. Here's where we really want you to focus. If you wouldn't mind, spend some time reading this nursing care process for clients with diuretics. Regardless of what diuretic they're on, this is really good information for you to commit to memory. Whether they're on a loop, thiazide, or potassium-sparing diuretic, a lot of this information is generic to all three. And then there's some specific points that are specific to potassium-sparing diuretics and specific to loop diuretics. So let's review the key concepts. The kidneys regulate fluid volume. They eliminate fluid depending on if your body is over filled with fluid or fluid volume excess, or they have crackles or edema, they might be considered or placed on a diuretic. Kidney's job is to eliminate fluid or excess fluid. Also, by eliminating sodium, it removes water from the body. If for some reason you're hypotensive or hypovolemic, your kidneys would hold on to fluid, so they would prevent the removal of sodium from the body. They also play a role in acid-base imbalance, but we're not going to get into that at this time. The kidneys are basically, I want you to think of them like a coffee filter or a filter in your coffee machine. The functional unit of the kidney is the nephron. We have over 1 million. We don't see signs and symptoms of kidney disease or kidney damage until after 70% of those nephrons have been destroyed. So when we start to see signs and symptoms of acute renal failure or chronic renal failure, we're in significant trouble. Those kidneys can be damaged. Think about it like this as well. We can give a lot of medications that can be nephrotoxic or hard on the kidneys or damaging to the kidneys. And if we do that and the clients don't monitor themselves or monitor signs and symptoms or get frequent lab checks, there's a potential chance they could have damage to that kidney. Also, uncontrolled high blood pressure can result in damage to the kidney. Dosages may need to be adjusted periodically. So they may need to go up or they may need to go down. That's why it's important to keep appointments. Diuretics for drugs increase urinary output, so we want to take them early in the morning. Caution them about orthostatic hypotension. Hold them if they are hypotensive, and hopefully you know what that blood pressure is. Hold them if they have signs of hypokalemia for your loops and your thyroids, or if you have signs of hyperkalemia with your potassium-sparing diuretics. And there you go. That's pretty well it from our chapter.